Okay, welcome, dear friends and comrades. And I'm very happy that we can start with this session tonight. It's a global day of action of the People's Health Movement. And we, as PHM Germany, are contributing to it with a panel discussion and access to COVID-19 vaccination only for the rich, question mark. The highest attainable state of health is a fundamental human right. This includes access to vaccines and medicines for the rich and for the poor all around the world. And it includes access to research results. This is not a privilege, as some politicians in Germany say, that people can be given or taken away, but it rather is a right that people have as they are born as human beings. That means the People's Health Movement, health for all now, health for everyone. This is committed to PHM. A year ago, we founded a German-speaking circle, PHM Germany. We are now around 50 people, currently from Germany and some from Switzerland. But other German-speaking countries and people are most welcome to join. Tonight, we will hear testimonies from India, South Africa, and Brazil, where the right is inadequately implemented. And we hear stories from Germany, from a rich country where many more than people from other countries are vaccinated. Today I heard in the news that of the poorest countries, only 1.5% have had a vaccine. Yeah. So not only we are safe when everyone has been vaccinated. Access and the right to vaccination is for me a matter of social justice and democracy. It means that everyone, everywhere in the world, can get vaccinated. Not that everyone has to be vaccinated, but everyone can get vaccinated, has access to it. Thanks. Have a good evening.
Thank you very much, Christiane. Yeah, well, welcome from my side to this international panel discussion. Access to COVID-19 vaccinations only for the rich? Question mark. My name is Astrid Böhner-Rodoreda. I'm a founding member of PHM Germany. I'm also a researcher and PhD candidate at the Heidelberg Institute of Global Health. And I'm pleased to present a truly international panel tonight. We're covering countries from Asia, Africa, Latin America, and Europe. I will introduce the speakers one by one before they start giving their presentation. Before we start, let me just change to the second slide. We would ask you to mute your audio. We are, of course, very happy to see your face when we come to the Q&A session, so please feel free to put your camera on. It might be best to probably switch it off while people are speaking. It usually, makes it a little bit easier than to understand. It serves the connection. I also want to alert you to the fact that we want to record this session. So by joining this session, you agree to the recording. So if anyone has got reservations or problems about it, we would have to ask you to leave the session and then listen to it later when it's put on the website of PHM Germany. But I hope that no one has got a problem with it and that you all stay put in this session. I would like to ask my colleagues, or want to thank also my colleagues at PHM, Eva Mainz and Santosh Mahendraka for monitoring the chat. We would like you to put your questions and your comments into the chat. You can use English or German, whatever language you feel more comfortable in, and they will monitor the chat and bundle the questions for the Q&A session. We will also, as you know, this session will be in English. If anyone has problems understanding English well enough, we have got someone who can provide a short summary in German. So if you need that, if you feel you can't follow the session well enough in English, then please put a 1 now in the chat. If you put a 1 now, we will go for, have a summary translation. If no one puts a 1 in, we assume that everyone speaks English and understands English well enough. Yeah. So we have 4 inputs tonight from different parts of the world. And I'd like to turn our attention, first of all, to South Africa. As many of you know, in 2020, towards the end, a new and more contagious variant of SARS-CoV-2 emerged in South Africa. It is the country that's already hardest hit by COVID-19 on the African continent. Our first speaker is Andy Gray. Andy, thank you for being present tonight, for sharing information with us. Andy is a senior lecturer in pharmacology at the University of KwaZulu-Natal. He's also a consultant for CAPRISA, the Center for the AIDS Program of Research in South Africa, and a WHO consultant. Andy, Peter Maberduk of the US organization Public Citizen spoke of vaccine apartheid about a week ago to describe the global situation with access to the COVID-19 vaccines. What is your view on this? How would you describe the situation in South Africa at present? Over to you.
Thanks very much, Astrid. So certainly the situation in South Africa is one of a lack of access. So let me share my slides, if you can confirm that you can see them. Okay, got it. So let me take you through a short presentation on the access to COVID-19 vaccines in South Africa. Before I go there, I just need to point out that I serve on a number of ministerial advisory committees, selection and regulatory committees in South Africa, but I speak here tonight as an independent academic and not on behalf of any of those. So I want to give you a snapshot of our pandemic, a little bit about the variant of concern, what sort of excess deaths we've seen, and then to focus on our vaccine procurement, what the problems are with local efficacy data and the national plan. So in South Africa, we have conducted nearly 10 million PCR tests, identified 1.5 million cases, of which nearly 53,000 have died. But you'll see on the far right-hand side of that slide, we have only vaccinated 269,000 people. That's 0.4% of the population of South Africa, which is close to 60 million. So how have we landed up being able to identify so many cases, lose so many, and yet vaccinate so few? Firstly, the COVID-19 pandemic has affected the country in a different way in different parts. It's disproportionately affecting some provinces more than others. And the Eastern Cape province down here in the south of the country has proportionately the highest mortality. It's more rural and more under-resourced. Most of the cases have been found in Gauteng, the KwaZulu-Natal, the Western Cape, and the Eastern Cape. Gauteng in the middle there is the most populous of the provinces, but you can see how small it is and how densely populated that would be. South Africa has experienced two waves of the pandemic so far. One in our winter of last year, and then a second wave towards the end of the year. And that second wave was associated with a new lineage, 501YV2, also called B.1.351. And it appears that that was not only easier to spread, but also associated with increased in-hospital mortality. That variant is uniquely identified in South Africa first. That doesn't mean that it was first developed here, it was first identified here. And the first cases were found in that Eastern Cape province and then spread to the Western Cape and KwaZulu-Natal, where I'm located. It has 8 different mutations in the spike protein, and 3 of those seem to be very important for how this virus is able to link to our cells and insert its genetic material into human cells. I said that we'd had nearly 53,000 deaths. Those are deaths in which there was a confirmed diagnosis of COVID-19. But if we look at our death certificates for all causes in anyone over the age of 1, we can see 2 spikes over and above what we would have expected based on historical data. And you'll see a spike in the middle of the winter, for example, and there's another spike in the middle of the winter coming. That's the normal pattern. But we've seen 2 enormous spikes and perhaps 2 to 3 times as many excess deaths compared to normal. And those are associated not only with COVID-19, but with the disruption to our health service as a result of the pandemic. So what were the options that we had in the middle of 2020 of where to get vaccines? We knew they were coming, we knew they were being developed, but there were none yet available. So one option was to go multilaterally through COVAX, the vaccine pillar of the Access to COVID-19 Tools Accelerator, ACT-A. And that would be a way to buy vaccines, not get them for free because we aren't a Gavi eligible country, but to be able to buy them together with everyone else. We could also have looked to the African Union, and there's an African Union vaccine acquisition task team. Or we could look to our partners in the BRICS, Brazil, Russia, India, China, and South Africa, which have some degree of commonality and common purpose. But mostly, the South African government decided it would need to go out and buy on its own, bilaterally, between itself and potential suppliers. And we hoped to be able to buy some vaccine that was perhaps not produced locally, but at least filled under license in South African factories. The challenge was whether the vaccines that were developed would work in the South African variant. And that photograph shows our Minister of Health and our President welcoming the first 1.5 million doses of the AstraZeneca vaccine procured from the Serum Institute of India. But just as those arrived, so the results of a small part of a vaccine study conducted in South Africa in 2,026 HIV negative adults showed a very low efficacy, only 10.4%. And that really set the cat among the pigeons. What would South Africa do with these 1.5 million doses? Subsequent to that, we've seen another vaccine which was being trialed in South Africa showing reduced efficacy. You'll see 89.3% in the United Kingdom, only 60% in South Africa in HIV negative patients. But if you added HIV negative and positive, it missed the target of 50%. And the lower end of that confidence interval, which we hope should be higher than 30%, was only 6%. So what's confused a lot of people is what South Africa has been doing over the last month. We were able to secure 500,000 doses of the Janssen Johnson & Johnson vaccine from leftovers of the clinical trial stock, so before it was registered anywhere in the world. And those 500,000 doses are being used in South Africa in a trial called Sisonke as an implementation study. So it's phase 3B, it's not yet registered yet, and it's being used in healthcare workers, not just health professionals, but anyone working in the healthcare environment. Allocated 70% to the government, 30% to the private sector. And we knew that this vaccine had 64% vaccine efficacy in South Africa, and even better, 82% protection against severe disease. So that's where the 269,000 people who've been vaccinated so far in South Africa have received their vaccine.
Muted.
What makes it a little different is that Janssen has contracted with one of the South African companies, Aspen Pharmacare, to fill, finish, and package that vaccine at their plant in what used to be called Port Elizabeth, is now called Gqeberha.
Okay.
And because that vaccine is going to be filled inside our borders, we've been able to put some pressure on that company. So initially, the government had procured 11 million doses from Aspen Pharmacare. They are in final negotiations for an additional 20 million doses. That would give us 31 million people, because this is a single dose vaccine. We have confirmed the purchase of 20 million doses from Pfizer. That would give us another 10 million people covered. At the moment, COVAX, which has allocated a small amount, enough for 3% of our population, can only offer us AstraZeneca or Novavax. And we know that those don't work, so we're not buying at the moment. And there are ongoing discussions with the Russian Gamaleya Institute Sputnik 5 and with two of the Chinese, Sinovac and Sinopharm. So where are we now? In an African sense, you'll see much of Africa has either no data or less than 100 people vaccinated. South Africa is a little bit better with 269,000 people vaccinated, but it's been a slow, delayed, stop-start process, complicated by our emergent variant and other factors. And importantly, what's also held it up is that we don't yet have in place a no-fault compensation scheme. But we are hoping that in the next 2 weeks, we are poised for takeoff. When those Pfizer doses hit our country, we should be able to see some sort of movement going forward. So I'm happy to take any questions, Astrid, and I'm happy to update you on anything which you don't understand from that presentation. Thank you.
Thank you very much, Andy, for this comprehensive overview of the situation. And yes, it is rather depressing, how few vaccines are available in the whole of Africa and for South Africa. I wonder if you can, there's another, I think, important action that happened last year with South Africa joining India in requesting a waiver at the World Trade Organization for certain provisions of the intellectual property rights agreement. Can you fill us in on the waiver and where this whole process is at present? And can I just ask everyone just to mute yourself when you're not speaking so that we have not so much background noise. Thank you.
Thanks, Astrid. So yes, South Africa and India have applied to the World Trade Organization asking that it use an existing rule to say that certain provisions of the trade-related intellectual property rights agreement should not be implemented. So that's the waiver. We say stop using these provisions, and they are provisions that relate to copyright, to patents, and to undisclosed information, and to industrial design. Those elements of the TRIPS agreement that govern anything used to prevent, contain, or treat COVID-19 should be put on hold until we have got our way through this pandemic. So if we look at the moment, vaccines can only be made other than in the original manufacturers' factories if they license them. Is there a way to share this in a more structured way? And there are two options. One is pooling. One's saying we give this information into a pool, and the pool can then use it elsewhere. That's CTAP within the Act A provisions. No one is taking that option. The other option is to say, let's remove the barriers to doing this on our own. Let's ease the way forward. And about 100 countries are backing South Africa and India in this way, but they are being blocked by the major producing countries, not only in North America, but also in Europe, saying, let's not tamper with a system which is working. And it really goes to that debate. You know, Boris Johnson said, we are where we are because of greed. And many people went back and said, no, we are where we are because of government support. Both of those have elements of truth. So partly it was public sector money up front, and partly it was private sector investment. How do we find a way to ensure that there is no apartheid, and at the same time ensure that the products that are available on the market are safe, that they work, and they're of good quality? That has to be a regulated process, and there is a way forward, not just an anarchic approach to this.
Thank you very much, Andy. I'm sure we'll come back to that point and discuss it in more detail. Thanks.
Thanks.
Let's now move on to Brazil, a different part of the world. Brazil has played an exemplary role in the past in providing access to healthcare for its citizens. It's also played an exemplary role in HIV, producing needed medicines, taking the right measures for the medicine prices to come down. Our next speaker is Mateus Falcao. He holds a Master in Human Rights from the University of Sao Paulo. He's also a PhD candidate at the same university and an associate researcher at the Health Law Research Center and PHM coordinator for Brazil and consultative director for the Brazil Center for Health Studies. I hope I have not missed out any other functions. Mateus, with the current Brazilian president, we've seen a COVID-19 situation go out of hand. We are seeing pictures of cemeteries growing and growing. We're seeing new mutations of the virus. What is Brazil doing or not doing to make sure that the population has got access to COVID-19 vaccines? Can you update us, please?
Yeah, certainly. Thank you very much, Astrid. It's very good to be here sharing this panel with you all. I'd like to salute everyone. And just as you said, in fact, we are living a very hard situation. I come from a country with a beautiful tradition on public health, and now we are facing a disaster, right? So I hope I can share some of inputs from here. I wonder if you can see correctly my screen, my presentation. Okay, please let me know if it's not working. All right, so in the next few minutes, I'd like to provide a couple of insights for you on the epidemiology and political situation and immunization in Brazil. So we are facing now a second wave, as you can see in this graphic, from April 3rd. Brazil is facing a massive second wave, big amount of cases. You reached today a record on daily deaths, which is very sad. It was more than 4,000 deaths. And this has to do with COVID-19 being already the greatest public health crisis of all time in Brazil. I share with you a shocking information here. COVID-19 has killed more people in Brazil than HIV/AIDS. We reached today this number of cases, more than 300,000, as you can see. And this is highly due to our response. I mean, our government response, right? So before getting into this, I must share with you a couple of inputs from the Brazilian infrastructure. We have the biggest universal access public healthcare system. It's quite similar to the NHS in the United Kingdom. We call it the Unified Health System, SUS. It's based on the right to health. Furthermore, we are a federation, so there's a lot of autonomy for state level governments. This is going to be important very soon. And as a federation, the central government should play a very important role regarding the health system on management and funding. It was supposed to play this role, and this is exactly what's not happening now in this crisis. Concerning the political decisions, that we have seen in place here, we see that the federal government was highly unprepared from a technical point of view and highly against non-pharmaceutical interventions like social distancing and lockdown. We also saw a massive spread of fake news concerning the so-called initial treatment. So politicians backed by the government spreading that these two medicines, ivermectin and hydroxychloroquine, could save people from getting COVID-19, which is a lie, but people would rely on these two medicines and not taking the adequate behavior to avoid infection. So this is the very hard decisions. On the other hand, what's working in Brazil, if the central government is not working, we see a leading role of state governments on pandemic handling and a very important role as well from autonomous federal institutions. When I say autonomous, they have a lot of autonomy from the central government. So I'd say the research-based public foundation, Fiocruz, and the Brazilian Medicine Agency, Anvisa. These are two articles that were published recently from the research center I work on, the BMG. I invite you to read them if you want to look more about what's happening here now. They're very short, but they show the result of a research that we made in policy. And we came to the conclusion that the central government tried to spread the virus through contagion to achieve herd immunity. Certainly, this is a disaster, and that's why we are so against it. It's almost a crime, actually, an actual crime against humanity. So yeah, I invite you to read this article if you would be more interested in know exactly the details from the mismanagement in Brazil. Let's talk about a little bit about immunization. In this whole scenario of bad decisions from the central government, we saw the delay and the absence to procure vaccines in the world from the central government in Brazil. We have currently two vaccines that are being used in the health system, the CoronaVac, which is a vaccine developed by the Chinese-based company Sinovac, with clinical trials in these 4 countries. And currently it responds for 80% of the immunization program. We also have Covishield, the Oxford and AstraZeneca, that is also being used within Brazil. And for the future, we expect to close agreements very soon with the Pfizer and BioNTech vaccine, USA and Germany, Covaxin in India, and Sputnik from the Gamaleya Institute in Russia. Brazil is also developing its own vaccine, Butanvac. I'm gonna speak a little further about this one. And we also have procured some vaccines from the COVAX facility. It currently responds for less than 10% of the delivered vaccines, so it was not that important within the general strategy. What is important to highlight is that the vaccine in Brazil are being produced by state-owned manufacturers, which from my perspective offers an alternative narrative from this challenge of providing vaccines to the world during this crisis. We have 2 public laboratories, Butantan Institute and Fiocruz, which has these laboratories, Biomanguinhos. They are producing each of the vaccines. Chadox 1 would be the Covishield from AstraZeneca. It was through clinical trials and technology transfer. That's how they managed to get the technology. Brazil also has a great tradition in a national immunization program. So we have 40 years of tradition. In the 80s, we were able to vaccinate 18 million people per day against polio. But now we have as main obstacles to use this national immunization program the access to the pharmaceutical active ingredient that we still have to import from India. For now, we hope the public laboratories will be able to produce this as well, but for now they are not. And certainly the austerity measures that reduces the budget for the public system. We have a national immunization program that is quite similar to the Chilean one. And if you look in this graphic shows the ranking, the world ranking for vaccines against COVID-19 doses for 100 inhabitants. And you see here Brazil in the 45th position. This ranking only includes countries with more than 500,000 inhabitants. And if you look into Chile, that was a country which was very successful on procuring vaccines. They are in the 3rd position because they have this ability to procure that Brazil didn't have, considering the position from the central government, and they also has a national immunization program that works well, just like us. If it was not from the vaccine from China, CoronaVac, we would be in the 77th position. It responds for more than 80% of the vaccines being used in Brazil. We are seeing, just like in South Africa, and Ro was showing us, the emergency of some variants, which is a matter of concern. As far as we have concluded, and there was a new clinical trial that was launched today, the Brazilian variant can be tackled as well by the CoronaVac vaccine. So, which is good news, but we're still following this, especially considering the big spread of the virus in Brazil. But yeah, at least for now, we think these two vaccines, especially CoronaVac, can work against the Brazilian variants. Oh yeah, so vielen Dank, thank you very much. I'm available to answer any questions you might have. Thank you.
Thank you very much, Matthias, for giving us this good overview. And even though it's a pretty dire situation, and especially looking at the graph of the various countries and seeing how low down Brazil is. Can I also ask you, Brazil in the past was very outspoken on patent issues and often joined India and South Africa. Now you've got a different government. What is the situation at the moment with regard to the waiver that South Africa and India have brought before the WTO?
So in a very unexpected movement, considering that it is Brazil, the government opposed itself to the waiver. We as civil society and social movements raised this issue a lot, considering how important it was, but the government stand in its bad position against waiver. But last week, the Ministry of External Relations, External Affairs were put it out not by the president, but by the Congress. And we expect a new minister that might, who knows, change its position. Because the truth is, this claim for a compulsory license for suspending patent barriers are raising among the Congress, even between more right-wing politicians that would never support things like this. Because this is a very important barrier, right? So who knows, in the next weeks, we see a shift towards what Brazil used to be in the past, which was a very good position.
Thank you very much. Maybe for those who haven't joined from the beginning, we're hearing the inputs first, and then we'll have a Q&A. So please, write your questions, your comments in the chat. They'll be monitored, and you have your chance later to ask your questions. Let's move on to India then. India has been known as the pharmacy for the poor worldwide. Without India, in many parts of the world, we would not have access to medicines. And I think that became very evident in the HIV pandemic. Without Indian generics, the African continent could not have started antiretroviral therapy in the early years 2000. Our next speaker is Dr. Gopal Dabade. He's a medical doctor and health activist. He's convener of the All India Drug Action Network, IDAN. He's also president of Drug Action Forum Karnataka. and he works with a rights-based grassroots organization in his hometown. Hi, Gopal. I know it's very late for you, so thank you very much for joining us even at an unearthly hour in India. Gopal, will India remain the pharmacy for the poor in the COVID-19 pandemic? We see that more and more countries and regions of the world want the vaccines to themselves. They don't want to share the vaccines with anyone else. And we've had recent reports that that may also happen in India. How do you assess the current situation? We heard from South Africa that they got supplies from India. So can we still expect India to play this role? And I will put on your presentation. I hope everyone can see it. Over to you, Gopal.
Thank you very much, Astrid. Can you hear me?
Yes.
Okay. Thank you very much, Astrid, for that wonderful introduction. Wanting to know whether India will continue to be the pharmacy of the developing world. But I will give a brief, I will answer that question. But first, let me run through it and tell you what's happening in India. Just a very brief account and nothing much. See, we all know India has got things. One is Covaxin and the other is Covishield. Covaxin is by Bharat Biotech, which has 24 years of experience and has been exporting vaccines to about 123 countries. Covaxin is made of killed viruses, and it is isolated by the National Institute of Virology in India. The other one is Covishield, which has got a long history, which was Oxford AstraZeneca, manufactured by Serum Institute of India. Serum Institute of India is one of the world's largest. It manufactures around 50 million doses a month. So this is the brief background in which we can set the ball. In my talk, I have looked at the vaccine issue per se, and also added other issue wherever that is necessary. Can I go to the next slide, please? Yeah, India has been a big powerhouse, and we run a very big immunization program. It makes 60% vaccine and is home to about half dozen major manufacturers. And Serum Institute of India, as I mentioned, is the largest in the world. Can I go to the next slide? Yeah, this is where all India has been able to supply the vaccine. This is the Government of India's figures as on 15th March. And this is related to Covaxin. You can see that many countries have been covered, including some countries in Africa and South America. So it has been able to really make an impact now. Now, this is the rollout of COVID-19 is India's gift to the world in combating coronavirus. And remember, as a time where countries stepped up in a major way as a global player. Now, the rollout of COVID-19 vaccine collaboration with leading institutions had rescued the world from deadly coronavirus and is a contribution by the country must not be underestimated. Why this particular I want to highlight? It's because India itself is passing through a very huge crisis. There is a very big public health problem with regards to COVID-19 in India. And definitely, I will briefly explain the next few slides what are that hindering. Look at this graph here. This is of as of November 2020, and I know things must change a lot. But look how vaccines have changed. Now, where is India? India is third, and UK is there, and so this gives a rough idea as to how countries have and changed. Things have changed. The lighter color would have become darker because they would have procured and they have already cured. So this is give an idea as to where India stands with other countries. Next slide, please. Yeah. Now the biggest problem in India is we have to 1 billion people have to be vaccinated, including hundreds of millions of adults for the first time. So this is a very big, daunting, and a very unprecedented challenge. This is a huge challenge. We have to understand that uh, India has very diverse people, diverse culture, and people from north and south, east and west are culturally, educationally, economically very different stages of living, and including literacy. I mean, we have Kerala, and we have Bihar, Uttar Pradesh. We have literacy is really a challenge there. So within this paradox, and applies to all these issues. We will never have sufficient supply of vaccines. The prioritization of recipients is going to be a considerable challenge. This is very aptly said that unless we prioritize, and what India has done now is what of India has done is that we have just vaccinated the frontline health workers, and then we started with those who are above 60 years and those who are having comorbidities, and now so now the challenge really is how do we take this further. What are what are what are the mechanisms? One thing is that the vaccine should be made affordable. We have to understand that India has a very huge private 80% private sector, and only about 18 to 20 is the public sector. So given this is we have to make use of the private sector in utilizing all these vaccines. And what is the vaccines? I calculated it's about $3 to $5 in the day. If I take two vaccines, it will cost $10. $10 would be very expensive for an Indian. They most people cannot afford it. And so what should be made available is that vaccine should be made available for 15 seconds short and should be delivered as a single dose. So these are the real challenges. One is the price of the vaccine has to be made affordable, otherwise vast people cannot buy it. And second thing is certain technological things have to be evolved and it has to be made a single dose. So it is only when these two things are made available that we can take it further. Next slide, please. Yeah, so as I said, one of the biggest challenge, see, the biggest challenge is not just the vaccine in India at least. Most people talk only about vaccine, but what about the cold chain? In some parts of the country, there is very limited infrastructure, and there is huge disparity between the states, as I mentioned earlier. So addressing gaps in India's existing vaccine distribution network, which for a couple of years. So this is the real challenge. How do you meet this disparity within this country? Next slide. Yeah, I thought I will. So these are the real problems here. There's a very huge population to be addressed. There's a lot of poverty. There is, as I said to you, the public sector is very weak and is trying to gear up, and there's a lot of inefficiency. There is corruption, and so it is actually it's a combination of social, culture, economic problems all combined together to build it. how much we can really reach the last person for all. Next. Yeah, so this is delivery roadmap, and coming to shall I go to the next, please? Yeah, so this is something which just now that what is happening with the technology access pool, where companies have to share their know-how. The CTAP is empty, and this is one of the issues that we have been talking about. That, will India continue to be the pharmacy of the developing world? So back 1 year back, what happened was that the Oxford University announced that it is ready to have any partner who is ready to deliver its discovered vaccine. Serum Institute of India readily established its hands. In came AstraZeneca and said that we will join hands, multinational companies join hands, and then India and Oxford wrote the agreement, and they said that we will give medicines for the 92 poor countries all over the world. So this was what was the understanding. And in that will also this 92 countries, 4 billion people all over the world, and that's half of the world. Please imagine. And India agreed for that. But what's happening now is that in this pool, the developed countries are trying to snatch. So how can India, uh, which is unfortunately the only country which is the pharmacy of the development, help this? That is so huge, and it's really a matter of pandemic, and it's not just one pharmacy of the poor. We need many countries, and I think for that, as I said, we need to open up the patents issues, and the joint statement issued both by South Africa and India needs to be respected by all over the world. Next slide, please. Yeah, I propose that we walk and chew gum by also focusing on immediate needs of dozens of poor countries. Get to vaccinate a single person. People are dying. See, the real issues I mentioned about the 92 countries, many of them just haven't had anything at all. I think this is a very, very urgent and a very pressing issue. And for this to happen, it's not just India which has taken the burden of the pharmacy of the developing world, but we need many more pharmacies all over the world. Yeah, vaccine nationalism will kill all of us. No one in the world is safe till each one of us is safe. I think these are very common statements that are made. Next slide, please. Yeah, so thank you very much. I'm sorry, I'm having a lot of internet connection problems, so can't help it. I apologize for that. Thank you very much.
Thank you very much for this presentation, Gopal. Yeah, we could hear sometimes, it was a little bit hard to hear. So you may have to repeat some things that you already explained again in the discussion. Can I just, come back to one of your last statements? Vaccine nationalism will kill all of us. You described the situation. India has a huge population. It's a huge challenge to make the vaccines available for the Indian population. At the same time, without India, I think we can probably forget about COVAX. So how do how is India gonna address this tension?
Yeah, as I mentioned, I think it's really very tough for India, and there are so many challenges, as I mentioned, for the Indian Health Ministry as such. So, given this situation, the global crisis that has happened, I think the best way out is that the TRIPS Council should respond to the joint statement issued both by South Africa and India, and every country in the world should come out and say that. And unfortunately, even Brazil has opposed it. I mean, it's very, very unfortunate. Canada has opposed it. So, and these are the very countries who need the vaccines. So it's a paradox. It's a huge paradox, and just not India. We need many more countries which will be the pharmacy of the developing world. I think that is a solution, not just India. Thank you.
Thank you, Gopal. Now we're coming to Europe and to Germany, high-income countries, and we've seen over the last year that about every country has their own policies when it comes to COVID-19. We've also seen that the EU ordered a lot of vaccines, 2.6 billion doses for its 750 million citizens. Our last speaker is Katrin Vogler. She is a federal parliamentarian. She has been in the Bundestag, our German parliament, since 2009. She's a member of the Left Party, and she served on various parliamentary committees, the Health Committee. At the moment, she's on the Foreign Affairs Committee and the Civil Crisis Prevention Committee. I hope that's right. Thanks a lot for joining us, Katrin. Katrin, we see a lot of tension at present in Germany and in Europe. On the one hand, people are complaining that the vaccination rollout is happening way too slowly, that, why are we not, managing the vaccination a bit better? On the other hand, we see a lot of vaccine nationalism. We see that, countries and the EU is becoming more and more reluctant to share the vaccines, despite the fact that it is supporting COVAX with 2.2 billion euros. How do you assess the current situation?
Thank you, Astrid, and welcome everybody. Yes, as Gopal said, I can just stress this: until everyone is safe, no one of us will be safe on this planet, because this is a pandemic, and we have to understand that a pandemic is a global situation where we cannot come out with nationalism. But governments in rich industrialized countries are pursuing a strategy of immunizing their own populations first, while using vaccines also as a tool for geostrategic influence. And this is one of the problems. We all, people and organizations who work for equitable access to healthcare and prevention, we were marveled at how quickly the development of vaccines and against COVID-19 was successful. For example, compared to vaccines against many neglected and poverty-associated diseases, from primarily less developed countries. And this was made possible by massive public investments, not only in the research and development, but also in the construction of new production facilities. For example, for BioNTech, the BioNTech factory in Marburg, in Germany, which was supported with an amount of 300 million euro taxpayers' money. Nevertheless, the principle applies that the exploitation rights remain with the companies. While almost all developing countries and emerging economies support India's and South Africa's application for a TRIPS waiver, the German government, the EU Commission, and the other traditional pharmaceutical countries are putting on the brakes. And there may be a lot of talk about technology transfer. We already heard this from the colleagues, but so far nothing really has been done and nothing has been implemented. And developed countries such as the US and the EU have ensured that no vaccine reaches developing countries through their exclusive orders. They exclusively ordered vaccines, although within COVAX, they had committed themselves to share it equally among all COVAX members. So this is really a breach of this international convention. So the EU is delaying the approval and ordering of Russian and non-European vaccines, so that they even fail to protect its own population as quickly as could be possible. COVID-19, in my view, it could have become a starting point for more global thinking and global action, and for more cooperation and international collaboration in research and action. But currently, it's more of an example of how nationalism, market orientation, and the right to profit impede real health care for everyone. Now, the TRIPS waiver dispute is an example of how economic interests stand in the way of comprehensive access to healthcare. By suspending patents for the duration of the pandemic, global production of vaccines, drugs, and, for example, ventilators could be increased and the prices could be lowered. While the federal government in Germany calls access to vaccines a global social good, it refuses to support South Africa and India's request to the WTO. And in this case, the WTO member states would have the right to suspend copyright protection for all products relevant to the management of the pandemic. And the rights holders would have to provide the states with all the documents they need for production. For the EU Commission, just to say it clearly and frankly, the right to maximize profits for a few is more important than the human right to access for health care for billions. And flimsy arguments are put forward that do not stand up to closer scrutiny. For example, it is claimed that the possibility of issuing compulsory licenses at the national level would be sufficient. Yet we have often seen that the big pharmaceutical companies and their associated governments have threatened poor countries that wanted to do just that with economical sanctions. And or it is said that intellectual property protection has no limiting effect on the availability of drugs or vaccines. This is completely bullshit. It's absurd. As we saw at for example, with AIDS, which killed millions of people in Africa and Latin America before the patents ran out, and under the conditions of patent protection of ARV drugs. Amnesty International today calls this failure a human rights violation. This is and this complete policy is completely irresponsible, even without if you ignore any humanistic concern. Because if the vaccination campaign is not significantly accelerated worldwide, we risk a severe, long-lasting health and economic crisis. The slower we move forward with vaccination worldwide, the more likely it is that new variants will emerge, and these variants will come to Europe, as will the Brazilian or South African variants, which have already arrived here. And if it takes 3, 5, or even 7 years in the countries of the global South to have sufficient vaccination coverage, we will lose a lot of development progress, and certainly we will not achieve the UN's global sustainability goals by 2030. But even in the countries of the EU, the supply of vaccines is still far from satisfactory, although they have invested a lot of taxpayers' money in research and development and even in building up production capacities. And we are in the developing and the least developed countries, we are even far away from thinking about vaccination to the most marginalized groups. So I also want to put an eye on these groups. For example, rural workers, migrants, refugees, and people in conflict regions. All those have to be reached. And so it's really, really important that we increase the pressure on our governments in the industrial countries and within the parliaments and from outside. The more people oppose the fact that their taxes are being used to develop vaccines that are then sold back to the states at many times the production price, the sooner the EU will rethink its policy. Therefore, support the European Citizens Initiative Right to Cure, which Astrid will soon present to us, because I believe this is a really important instrument for education about people, to educate people about the situation and to show out a way of this dire situation. And as I believe it should be available for signing in every doctor's office and in every pharmacy all over the European Union's member countries. And this would also pressurize the European Commission to support the TRIPS waiver and the giving giving more pressure to support the countries in the global south to provide the necessary vaccinations, drugs, and other things needed against the pandemic. Thank you very much.
Thank you very much, Katrin, for giving us the global picture and the responsibility of high-income countries and the EU. I just see a question in the chat from Andreas Wolf, who has got a question to you, Katrin. Why and how is the EU delay does the EU delay the registration of Sputnik V? Is the EMA not an independent body and should not act under political pressure?
Definitely, it should act as an independent body and not under political pressure. The pressure I see is that we need as much different vaccines as possible to reach the best effects. And we see that from that the EU countries and the EU itself ordered much and many vaccines from EU-based companies before they were released and before they were adopted by the EMA. But then not even go into negotiations with the producers in Russia, in China, or in Cuba, for example. And so this is questionable. I think this is another kind of pandemic nationalism.
Please feel free to put your questions in the chat. If I can just ask you, did anything else come up in the chat that's burning at the moment?
Not so far. There was a question from the beginning of the discussion about the PCR test and the antigen test. So if there's no other burning question, we can maybe discuss this quickly. Maybe to all of the panelists, because the question was when in the different countries is a PCR test performed and when is an antigen test performed? And does it really make sense to test both at the same time as they test different things? This is one issue we could discuss maybe one by one.
Okay, maybe we can leave it for a bit later because it's maybe not so intimately connected to vaccines. So I'll maybe put that a little bit on the back burner. I would like to start with Andy again. Andy, I just read a couple of days ago that there is again a new variant of the virus found in Angola by Tanzanians who traveled into the country. And I think we've all read that the former Tanzanian president, Magufuli, who unfortunately died a few days ago, I think held similar views of COVID-19 as Thabo Mbeki did of HIV. He very much doubted that it was a reality. He didn't think it existed in Tanzania. So not much was done in Tanzania, and COVID-19 spread and now seems to have led to a number of mutations. Now, how does one tackle these? You described the situation in South Africa that a lot of the vaccines are not all that effective against the new mutations. Now, as we're seeing more and more of these mutations, from a pharmacological point of view, how does one tackle these? Do we need, again, new vaccinations? Or, how can we make sure these vaccinations are effective against the various variants that are in circulation?
Thanks, Astrid. Really good question. So the first thing is that we need to ensure that wherever there is spread of the virus, that we get a handle on what the variants are that are prevalent in that area. So the capacity to sequence is really important. Those laboratories don't exist everywhere in the world, but moving those samples to a laboratory that can sequence it is going to be really important to understand the spread of the virus and where those variants of concern might be becoming the dominant ones. So as to how much in Angola might be sequenced and whether they are able to really say where those variants come from is probably a little uncertain at the moment. So what we will probably need is an idea of whether existing virus vaccines work against those variants. And that's easy when they were tested in an area where the variant already existed. And so in South Africa, we know when the variant started to emerge in around September through to December of last year. And so studies that were being done around that time will tell us something. What we don't know is whether older vaccines or vaccines that were tested elsewhere work against it. And there are some laboratory tests that can be done, but they don't really tell us about vaccine efficacy. We also don't know if particular constructs of vaccine are better or worse at that. So if they've very directed the mRNA vaccines or the protein subunit vaccines compared to the more old-fashioned whole virus inactivated vaccines, there might be a difference in the way in which they deal with variants. So it may be that more old-fashioned vaccines like those produced in China, but also now in a French study that is just going into phase 3 now, might actually be the best way forward. But I think Katrien's point is an important one. We need a range of vaccines. We need a variety of sources, but we also need a variety of producers. And we can see all over the world that as one avenue closes, another one opens. So CSL in Australia was developing its own vaccine. When that didn't work, they very quickly licensed someone else. How do we get the barriers to those licenses removed so that we can increase the number of producers and share the know-how on how to do this? because this isn't a problem that will be solved by one firm. The Poonawallas are the largest producers of vaccines in the world, but they are unable to produce everything. They've got all their eggs in one basket. We have to have a lot more eggs in a lot more baskets.
Thank you, Andy. I see there's another question in the chat box. Will the waiver and the abolition of patents be the solution? There's always a comparison with HIV medicine, but isn't it more difficult to produce vaccines? So you need all the know-how and infrastructure.
Absolutely. So we keep learning that this is not simple. A good example is the Emergent Biosolutions factory in the US in Baltimore, which had enormous amounts of money poured into it by the US government. And yet when they tried to produce vaccine, they got it wrong. So this isn't as simple as small molecules, but that doesn't mean that some of the same solutions can't be applied. And I think that CTAP, in addition to the waiver, CTAP is an option that has so far been ignored. We know that it's worked very well with the medicines patent pool. We know that it can be applied beyond HIV, TB, and malaria. Let's see if we can use that mechanism to have a more regulated and controlled and careful technology transfer, but without having to resort to one-to-one relationships. I think it really is a way forward.
Oh, sorry, I was silent. Mateusz, would you like to add something to that?
Yeah, I'd like to agree with Andrew. I think I agree with, I'm sorry, who asked the question? Let me just check here in the chat. Julian, that asked the question. Yeah, I agree that patents, they are one barrier, right? We also have this technological barrier. I think this is why the waiver also includes other IP rights beyond patents. And I agree with Andrew that CTAP would be a nice solution. But moving a little bit wider than COVID-19, we have been discussing this a lot here in civil society in Brazil, in a movement to access biotechnological drugs. How fight against patents is important, but we need to move forward and start to get into other issues as well, like industrial policy, sharing of technology, initiatives like CTAPs, and even things like public laboratories and within public technological innovation that could lead to the scale up of producing of these technologies. I think that the WHO Commission on Economics, led by Mariana Mazzucato, which was recently established last year, will provide good inputs on that issue as well. So yeah, I just would like to share this thoughts.
Thank you. I also see another question here. What would be the options for poorer sub-Saharan African countries other than South Africa to go beyond COVAX, the 20% that they're going to get? AVAT, debt relief, a waiver, and maybe I can widen the question a bit. Maybe we can go beyond Sub-Saharan Africa and look at low and middle income countries in general. I don't know who of the speakers would like to take the question. Maybe Gopal?
Let me try and start on that one before Gopal comes in. I think a really key issue is financing. So what we don't want to do is sink poorer countries into more debt than they already are in. So yes, debt relief is one mechanism to free up funding. But really the answer is that those countries will never be able to pay for themselves. And this should be seen as an international solidarity issue. And as Catherine said, it's in no one's interest to have pockets of the world where the virus is continuing to replicate. It's in everyone's interest to ensure that those parts of the world are catered for. And so I'm afraid there is no better option than overseas development aid in this regard. In financing AVAT, in financing access for individual countries in using the waiver in order to ensure that there are a range of suppliers that they can buy for. So unfortunately, the answer is never one or the other, but all of the above. And really that has to be the answer for every single mechanism to be applied simultaneously in order to ensure that the whole world has access. Because if it isn't equitable, it's not going to be effective.
Thank you very much, Andy. Would others like to chip in?
Yeah, can I just what Andrew said? Thank you, Andrew, for making this topic simple for me now. I just want to tell few things that a poor country like Ethiopia is paying 3 times than what UK pays to get its vaccine. See, this is the sort of marketing of vaccine is what's happening. It's very, very unfortunate. And let me tell from my own Indian experience, of course, we know what happened in the Novartis case. India in 2012 granted compulsory licensing only once in its lifetime. And the company which was granted compulsory licensing was Indian generic company Natco. And the patent was held by the German company Bayer. And when the compulsory licensing was granted, what happened to Natco? It was really pushed aside, punished, penalized, so that it's nowhere. This is I think this mindset, this attitude has to change, and that let's all come together. This is a global pandemic. You cannot sit in one's house and solve this problem. No, it has to be, as Andy rightly said, it has to be all of the above, and it has to include every one of us in this fight against this global pandemic. Thank you.
Thank you. I see another question here in the chat from Yasmin Ackermann. Katrin mentioned the tax subsidies were heavily used for production facilities for BioNTech. How far were they used in the development, not production of the vaccine in the first place? I think this is a vital point in arguing for public access to intellectual property. Do you agree? Katrin, I think this is directed at you.
Definitely it is. The situation is that we don't really know how much the companies themselves invested in development and research. But what we know from former vaccine development programs, we can say that up to 75% have been publicly funded. And we know from BBC chart, which the BBC published, that in most COVID-19 vaccine programs, this is even higher, that it's up to 90% or something like this, or even 100%. And what should not be forgotten is that the basic research often has been done in public universities and public institutes. For example, BioNTech is a outfunding company of a university institute where have been all the basic research on the principles on which this vaccine is based. So there's invested a lot of money, a lot of taxpayers' money, but the risks are also often socialized. For example, when pharmaceutical companies pressurize poor countries to take over the responsibility for any damage done by the vaccines, as they did, for example, in Bolivia. So the risks are socialized and the profits privatized. This is the principle and how the whole thing works. And this is not very rational, and it's not very intelligent. We could do it much more in an intelligent way, as Mateusz said, when we invest more in public research and public development, and we could give the licenses of the for production to the private companies, and they can also do some profit, but not that huge profits as they do actually with publicly funded research.
Thanks, Astrid. Can I just add something there? A lot of people are saying, how on earth did we develop a vaccine so quickly? The answer is that we didn't start a year ago. We started after, in a way, 9/11, but also the anthrax attacks in Washington just after 9/11. What woke up the world was a biosecurity concern. And so many countries invested in vaccine production capacity, but they also invested in the basic research to look for a platform, thinking about what they call disease X, this thing that's coming down the path, but we don't know what it is. Let's build the basic constructs and think about how we'll be able to adjust them. We tested it with Ebola and we tested it with Zika, and now we've been able to apply it. But really the key there is government put the money in. Now government has to have the guts to enforce its right to the information that was developed. And that's where the failure lies, is not the realization of how much they invested, but the willingness to say it is ours and we are going to hold on to what is ours. That it's like the Bayh-Dole march-in rights under US law. It exists on paper. It's never been exercised in fact. And that is the key for those governments that have invested to not only see it as, thank you very much, we've got the vaccine, but what else do we own about this in order to ensure that everyone has access? Thank you.
Please unmute.
Yeah. Astrid, I think Eva has a question and Matthias wants to input perhaps.
Okay.
Maybe Matthias, you can say your comment because I have another question to you after that.
Yeah, it's going to be a very quick comment. I guess Katrine and Andrew covered a lot about this public investment. I would like to bring the Ebola vaccine that was almost fully developed by public investment, even the clinical trials. It's already a good example. I also, we're going to share, I got the previous question on the sub-Saharan African countries. There's a program by WHO from meningitis vaccine in which WHO procured vaccine from public labs in Latin America, in Brazil and Cuba, and distribute them among these countries. I think this is an example of alternatives that we can see that we can look at to in order to think of different ways to approach vaccine and immunization policies, not only looking on the multinationals and I mean all that business as usual, right? I think the suspension of patents are key, very important, and beyond that, we also need public health oriented industrial and innovation policy. I'm sharing the article in English in the chat.
Thank you. Eva, do you want to?
Yeah, just before you share that, you already did. I have another question to you, Matthias, because we were just talking that apparently the whole European Union failed in putting conditions to their public money, as Katrine mentioned and we discussed. So you were mentioning that for the AstraZeneca vaccine, there was technology transfer because the clinical trials took part in Brazil. So was it engagement from the government, or how were these deals done? You know.
May I answer? That's right. Okay, perfect. Yeah, so I think just one quick comment. We are still not producing the pharmaceutical active ingredient. on the AstraZeneca vaccine. This is a very important remark. We expect to start to produce it nationally by September, which would be amazing for us, but still not. So I wouldn't say that is a total success, but we are expecting, so let us see. But if succeed, I think it's highly due to the power, the political power that this public foundation have in Brazil, Fiocruz. It is a national public research foundation. It was founded more than 100 years ago, and it has a lot of autonomy from the central government. And today it's totally oriented to realize right to health through research, right? So I think it relies certainly on civil society engagement, campaigns, parliamentarians that struggle for right to health, but I think it has a lot to do with all the power that, I mean, in a good way, right? The power that this institution has. Because this institution, Oswaldo Cruz Foundation, has played a significant role in the last decades by providing cheap medicines and mostly cheap vaccines to the public health system in Brazil. That's why everybody knows that this is key. We are not a rich country, right? So we cannot afford vaccines to keep our program. So I think this is within the Brazilian political scenario, this would be a very important political component to highlight. I don't know if it was clear, if I answered correctly your question. Was it?
Now, can I just follow up one of the questions in the chat about CTAP? What is the solution to fill CTAP with the technology that countries can use? What do you, maybe that's a question to all four speakers. Maybe I'll start with Gopal this time because you already mentioned it in your presentation.
Yeah, I think things is that the is need a broader understanding and look at the pandemic that is killing people and all. And there is an urgent need to address these issues. So basically, I think whether rich or poor or whatever, developed or undeveloped, it's very important and very urgent that countries should come together on a platform and not try to hit each other through trade on patent issues. You cannot hold on to these issues and say that I want to make more profit when people are dying. See, this has happened several times in the past, and now it's happened. Well, when it happened last time, it happened in South Africa, it happened in some places like that. But now it's happening all over the world, and I think it's very urgent to wake up to the call. And the call is all countries need to come together on a platform and see how, as Catherine rightly said, that the last person in this, is vaccinated. Thank you. And just last one point. Let's not forget that vaccine is only one component. We need to improve the public health system in these countries. We need to see that countries don't go into because of these patients. We need to address the issues of access to entire technology, not just vaccines, but also drugs and access to medical technologies, respiratory, masks. There's so many things even on masks, I feel, as of right now. This is anywhere. And I think Catherine really gave a beautiful background setting to this entire issue as to how public money is really going into this. And the money is being pumped out. So the core issue, thank you very much.
Thank you very much. And perhaps Katrin would like to answer too. I see you've also put something in the chat box. I think since we're not so many people, feel also free to unmute yourself and ask a question. But the word is yours now, Katrin.
Yes, I think Andy was right when he said that the governments need to have more guts to go into quarrel with the big money or with the big companies on public health issues. But there's also another point I want to make strong. We have seen in this pandemic that the dependence on very on a very small number of production facilities for the whole globe is not really the way we can continue. We need a more broader approach, even in a globalized capitalistic world, to have local or regional production premises, not only for vaccines, but not only for medicine, drugs, but also for protection issues, for medical products, everything. And we need to invest in what Gopal said, in our public health systems all over the world. One point that drives me really crazy is that in the situation where we have the deepest crisis in every one of us, his lifetimes, I think, then we see that still 2 trillion of US dollars are invested in in armaments and in military, and that the rich people are getting richer and the poor people are getting more and getting poorer. Although we know that the poorer people get, the more they are getting to be victims of this disease and of other diseases, and so this is a social question. So when we cannot convince the industry to share their technological knowledge, then we must force them. And we have the instruments, for example, in Germany with pandemic laws. We can do this, but our government does not want to.
Okay, thank you. Are there any direct questions?
I see Chris Knaut is...
oh, sorry.
Yes, thank you.
Chris, please go ahead.
Yeah, my name is Chris. I belong to the, as Wilbert, who is also in this call, to the founding generation of HI, but over the last 20 years, I have been working for the European Commission in Health. I'm happy that Gopal has already raised a point I wanted to stress. Medicines and vaccines will not save any life unless we have functioning and accessible health systems which are able to deliver those to the people. And the cartoon Gopal was showed it a bit. I mean, I'm working in Sudan, and unless you have a cold chain and you have a functioning system, the arrival of vaccines at the airport in Khartoum will not solve so much of the problem. So we should not forget health systems and health system strengthening when we discuss and limit our concerns to the technologies and the medicines and the vaccines only. The second point is to my previous question on how to go beyond COVAX. I think it's time also for the movements in the world to question the existing global initiatives. I mean, a global fund only to fight 3 diseases is no longer fit for purpose in this world. What we need is a global fund that helps countries in need to function their health systems. Due to the global fund, we have lost a decade from 2000 to 2010 of health system strengthening, where the whole rhetoric was to fight 3 diseases only. We now see that the health challenges go beyond these 3 diseases, and we need to say we need a global financing mechanism that responds to all health needs beyond those three diseases. We have to say those people in the Global Fund, the model you created in 2001 is now outdated. We need something different. We need a mechanism that helps developing countries, particularly poor countries, to achieve universal health coverage and to give global access to health and go away from this disease focused, and particularly this free disease only focused approach. So we should look beyond the questions we are discussing here. I truly believe that vaccines are the most, probably the most important part of the solution of the COVID challenge, but it will only work once you have universal access to functioning health systems. Thank you.
Yeah, thank you for raising the point of health system strengthening. I think it's an important point. We might disagree a little bit. I still think, the Global Fund has and still is a very, very important set up to help countries, and it has already widened, I think, to also support health system strengthening. But we obviously need more, and I wonder, Matthäus, would you like to say a little bit more? You also mentioned the BioNTech vaccine that you're using in Brazil. How is Brazil coping with the cooling chain?
So to answer this question, Astrid, I'd like to start by actually what Chris was saying now, how important it is to have a developed health system, right? Besides having this terrible president now, we are in a way thankful in Brazil because we have a kind of developed health system considering our position as a low and middle income country, right? And this is due certainly years of social struggle for right to health. And this immunization program includes these cool chambers that you just asked. We would be able to provide them at big cities, but absolutely it would be a challenge. That's why we think that the best way for us would be scaling up production of the current vaccines, CoronaVac from China, from Sinovac, China, and the Covishield. If we had access to the pharmaceutical active ingredient, if you could produce the pharmaceutical active ingredient, because we would be able to use the Pfizer BioNTech vaccines only in big cities, right? So this would be kind of the challenge for sure.
Astrid, can I just weigh in there quickly?
Sure.
And I think it's important for us to look back at our history and say, what was the debate in 1996 about antiretrovirals? We can't use them in Africa. People won't understand adherence. They have to take them at the same time every day, and that's not possible. We can't distribute them. We can't reach people. Our health systems can improve if there is the political will to engage in that. South Africa went from a denialist position to the biggest antiretroviral program on earth. We can do the same with vaccines. Capacity is plastic. It's not set in stone. So let's have a look at the beginning. We looked at the Pfizer vaccine and said, minus 80, it's impossible. We don't have a freezer that's minus 80. And now the evidence comes out, hang on, you can store it at minus 20 for 2 months. And we go, but minus 20 is normal. That's what we do for all of our childhood vaccines. Suddenly we have the capacity. So the world moves, the evidence moves, and the capacity will move. So let's not see these things as all, yes and no, black and white. They can all be changed if there is the will and the means to do it.
Thank you very much. Yeah. Matthäus, would you like to?
No, I was just clapping hands for Andrew. I agree.
I'd like to, Katrin already mentioned the European initiative. Let me see if I can share my screen. You all see this? This is the web address of the European Citizens Initiative. And it's basically an initiative, no profit on the pandemic. That COVID-19 vaccines have to stay a public good. As Katrin already explained, a lot of the research was also done with public money. It was sponsored. So it should stay in the hands of governments and not the pharmaceutical industry. And I think only European citizens can actually sign up. Is that right, Katrin? So you have to be living in a European country in order to sign this petition. But if you press the link, you get into it, and it also asks for a lot more transparency on the pricing from the pharmaceutical industry. And I think that's obviously a demand that I think many of us have made for many years, that one knows how the prices come about, which, yeah. And that, the states still keep in charge of the vaccines, because it's not something that we want to get out of hand with pricing, as we've seen with a lot of hepatitis C medicines, and where the prices are just moon prices and have nothing to do with the actual production of the vaccines. And I think we've seen particularly with India, how cheap some of the things can be actually produced. Katrin, would you like to say more to this initiative?
Excuse me, I was just writing something into the chat, so I was a little bit upset. I think you said all the things that are necessary. People should go on the page and spread it to everyone they know who is allowed to vote for the European Parliament, because these are the people who are also allowed to sign this petition. And when we get enough signatures, this must be debated in the European Parliament, and must be and the European Commission must refer to this in some way. This is not everything we can do, but it's one thing we can do, and I would really like to use this also as a instrument to build awareness on these issues.
Thank you, Katrin.
Chris has raised his hand.
Is there anything more from the chat?
Yes, there was. There was a more general question if intellectual property rights seem to be one of the major threats to accessibility of drugs and vaccines. Is there any need to work on this general problems of intellectual property rights?
I think this is one of the main reasons why the rich industrial governments and the EU are blocking the TRIPS waiver for now, because they are afraid that there is an international broad debate on intellectual property rights and how they hinder the global access to healthcare. And so this is an issue where we always have to focus on. But as we also learned today together, it's not the only issue. It's also an issue of having stable and well-funded and well-equipped public health systems with free access for everyone.
Would anyone else like to chip in?
Yeah.
Just a quick word from me. We have to, again, an appeal from me to learn from our history. We got access to antiretrovirals through civil society action. Let us not see ourselves as the small people who are ignored and not listened to. Our voice is loud and our voice is heard, but only when we speak. So let's continue to speak up and make sure that those in positions of power cannot ignore us, because that is what changed things many times over in many diseases and in many struggles in the world, not only in health. So don't stop.
I think the first step would be to get 1 million on the petition for Europe, then they have to speak about it.
Can I just add a small point? Can you hear me? Yeah. I think antivirals that we talk of and make accessible was definitely because of the gays movement. And we must all be thankful to those, those whom we considered as the weakest part of the society came out with very powerful words and came out very strongly on these issues. And I think ultimately we should go back to health for all. Being a people's health movement, we need to go back to what we said in health for all, and which was killed immediately after that. It was these big corporates we need health for all. We need primary health care, we need health for all, and these are the solutions, and not just tinkering with some technology. So that is, health is fundamental human right, and it has to reach every person. I think that is the message. If as PHM person, I would definitely say that. Thank you.
If I might add, just
Go
very
ahead.
quickly, because I was highly contemplated by the ones who spoke before me. I just would like to add, following Gopal, that it's very important. The COVID-19 crisis show how important it is to build worldwide movement as people's health movement, right? If you see as the power goes beyond nations and reach the global level, we also have to organize ourselves at the global level to make sure that health for all is a reality. So this is also something very important to highlight, that I guess COVID-19 shows us more than ever.
Thank you. I'd like to ask the panelist, what intervention, what action do you think would be the most appropriate action to reach equitable access to vaccines? And if you've got maybe your part of the world or the global situation in mind, what would you suggest? How should we go about it? Katrin, can I start with you?
I think we must challenge our governments so that they get the guts to mess up with a really mighty, with the rich and with the strong and with the big companies. And this is our task we have to do, and we must proclaim, not only proclaim, but also practice solidarity with our fellow world citizens in the poorer countries in the global south. And this is the only way we can change things. And after hearing from Brazil, from India, and from South Africa, I think we have partners there who work together on same level. We share the same vision of a world where really health is a human right and not just a privilege for a few, but the human right for everybody. And this is our vision that we share, and I'm very proud to be part of this.
Thank you. Gopal, can I move to you?
Thank you. I think we should start questioning the corporates. It's time now. They have messed up the world. They have weakened the government. I think they have weak democracies. I think very fundamental and very basic things. They have dehumanized rights. I think the corporates have to be questioned every step, and what needs to be done is democratic governments have to be signed, which will listen to the people's voices. I think this is what needs to be done at a very urgent war front. Thank you.
Thank you. Matthäus, what about you?
Yeah, I agree as well. I think corporate power is something very important. I also agree with Gopal on that. Considering COVID-19 vaccines, I think the waiver proposition is key for the world. I think to actually lift all the restrictions would include a mechanism as CTAP, but a mechanism that would be mandatory. So a mandatory CTAP could be very useful for us as well. I think this is important. And in a more like long-term or medium-term perspective, I think we could use this experience of COVID-19, this crisis that humanity is living now, to redesign our states towards right to health, which include right to health oriented innovation policies and industrial policies. This would be very key from my perspective as well. Brazil does that a little bit with the public laboratories, but I think this is a path we should move forward. I have high expectations from the WHO Commission on economies on health for all. I think they might provide good inputs from there. I'm not sure, who knows, but I think this would be an important thing to mention here.
Thank you. Andy, what is your vision and how do we achieve?
I think what everyone has to do is stop and think about what we actually mean when we say none of us is safe until everyone is safe. It's an easy slogan. It slips off the tongue so easily. But if we stop and think what that really means, that each of us has a stake in ensuring that someone else has access, that should make us think about what our priorities are and how we ensure that we are safe by ensuring that everyone is safe. And it's so easy to say solidarity is the way forward. That is not, unfortunately, what human nature seems to be wired to do, but it is what human nature aspires to. And let's make sure that we can get closer to that. We won't achieve it entirely, but we can't at all not at least attempt it. Thank you.
Thank you. And Andy, you mentioned before that we can all do something. And I think, Erica, do you want to say something more about what people can do about CTAP? Do you want to unmute yourself?
Yes. Can you hear me? Hello, Astrid. Long time. How are you? So thank you very much for allowing me to participate and share a few thoughts. Eva was asking me to explain a little bit more on CTAP. And since many participants mentioned CTAP as a possible solution to this problem through the sharing, not only of intellectual property, but also know-how or data to facilitate technology transfer that is needed now to increase the scale up and the manufacturing. Yeah, just maybe to mention that of course WHO encourages all the different initiatives, right? Our Director General is very clear and has a clear message in relation to the waiver as an option to facilitate access, and also the use of the TRIPS flexibilities, of course. But the voluntary mechanism setup seems to be kind of a more middle ground solution in order to try to facilitate both, not just sharing of intellectual property, but also transfer of technology. But the problem is that, as some of you said, that it is an underutilized mechanism so far, because the preferred way for the companies and the vaccines in particular is to do this kind of non-transparent bilateral deals that are not solving the problem because they have many restrictions. They are limited to few manufacturers, as all of you mentioned. So that is why CETAP is trying to promote this mechanism with more transparent licensing and tech transfer agreements, with more non-exclusive agreements, and also, of course, including all the important terms and conditions that promote access in this agreement. So how people can participate, I think civil society, as many of you said, had a very key role in supporting all these initiatives, because we know that it is not easy to convince the companies to join voluntarily, because it's a voluntary mechanism. But we need the support of the governments that are participating. The co-sponsors of the Solidarity Call to Action and CETAP are also actively engaging in discussing how we can find other kind of incentives to convince, like regulatory or financial incentives to convince the companies to join voluntarily the initiative. But we know that governments and civil society can facilitate this engagement with governments, and also with funders and with companies in order to do that. Thank you very much.
Thank you, Erika. And I'd like to thank all the speakers for your excellent inputs and for giving us more insights into the reality in your part of the world. And as Andy said it, and many others have said it too, this is, we could have learned, I think, a lot more globally than we have. It seems like everyone is trying out their own solution rather than working together. And we obviously need also more research. We need probably more vaccines, to cope with new mutations that will emerge. And we need the pressure to our governments to keep the vaccines as a public good and to work together in the one world, and not everyone trying to just protect their own population. That is not going to work for a global epidemic. And I think we've seen that, and hopefully we understand that and act differently. So thanks very much for everyone who's participated and asked questions or made comments. It's been a wonderful exchange. And Christiane, maybe you want to say something about how this will be put on the website of PHM Germany?
Yeah. If you go to the website of PHM Germany, which is phmovement.de instead of org, and I would invite you, the webinar will be in the website in the press corner, and the presentations, if the speakers agree, what I hope. Actually, I have them, and I will put them into a PDF, and they're on the website too. As we don't believe in patents, they're freely accessible for everybody, and you can make use of them. And you can also write to the speakers or to me, and you will get the PowerPoints.
Okay, thank you very much. And thank you very much to everyone. This has been a really interesting exchange. And let's hope that in the months to come, we will actually see the benefits of global cooperation and putting more pressure on the governments to keep vaccines and to make vaccines a public good for all, everywhere. Thank you, and we'll close the session now. Bye.